Hello friends. So now it's the era of AI. So I've done a video on AI in intensive care, a long video. So I'll just do a few series of these snippets as to how AI is making inroads in different dimensions of intensive care. So today, as you see the picture, friends, so we'll see what all studies so far has been done with AI in intensive care pertaining to respiratory system. So we won't. So it's only a snippet, 4 5 minutes. So there are not many studies. There are around 4 to 5 studies, and very interestingly, some of these studies have come in engineering journals. So it's very hard for you to read and understand the nuances of mathematics or physics they have utilized to create these algorithms when it comes to ventilatory variables. So I'll just keep it simple for our doctor community as to what is the advance that has happened in application of AI in respiratory intensive care. So it's just 4 to 5 minutes, just a snippet talk. So AI, as you know, friends, it is trying to replicate human intelligence, and algorithms are sort of created from the data sets to try and emulate and simulate human intelligence. So AI is valuable in trying to uh, sort of replicate human intelligence, and along with it, it has analytical ability. So whatever data is collated, and there is this analytical process that tends to happen to derive certain solutions and helps in the decision making. So these are the three important components as to how we are utilizing AI in the healthcare, trying to simulate our intelligence, doing having that analytical sort of a approach towards deriving solutions and having decision making. And it is a little different from machine learning. So what machine learning does, it takes a large sets of data and tries to segregate different data points and tries to recognize the pattern within the data. So it is a data, the pattern recognition sort of a process that happens in the machine learning. So it interprets the data, segregates, stratifies the data, and looks into some, make some semblance of what data is telling is machine learning. So there's a little bit of a difference, but they are used interchangeably. But just for our audience, just bear this in mind. So let's look into AI and respiratory system, how it is doing. So they have created algorithms, and they have trained these algorithms to analyze the flow rates and the airway pressure. And based on the algorithmic approach on taking large data of the flow rate and airway pressure, so they have trained the models to calculate resistance and compliance with regression models. And by using this regression model to analyze this flow rate and airway pressure, they have tried to compute the resistance and compliance, with what accuracy, friends? With 99.4% accuracy. And this is a published data from Hazard Jayabi. This is from US data, where they've used large sort of a data sets of flow rates and airway pressure, and with algorithms, breath to breath resistance and compliance has been computed with 99.4% accuracy. And they have used this as a trial. And AIs are able to predict optimal timing for the weaning. And there is a study which I will talk about. And they have the third sort of an advancement in AI respiratory is to look at phenotyping ARDS. We're all talking about ARDS. You go to a conference, you'll have this brilliant speaker talking about phenotyping in ARDS. So we know in ARDS, we have divided into P1 and P2 phenotype. So the P1 ARDS is predominantly ARDS, which has a unique characteristics secondary to polytrauma and ARDS, they tend to recognize. And P2 ARDS, they found that they have higher IL-6, IL-8, plasminogen activator inhibitor. They have tumor necrosis factor inhibitor receptor. And P2 ARDS tend to have higher heart rate, higher minute ventilation, and hypotension. So the typical sort of an ICU ARDS we tend to see possibly falls more into P2 category, is what we could deduce from the data that is available. So AI is used in calculating resistance and compliance, breath to breath from flow rate and airway pressures by using regression models. And they have looked at predicting optimal timing of the weaning and trying to understand the phenotyping of the ARDS, which helps us in customizing or calibrating certain interventions in ARDS. So this is where AI has made progress. So this is the article that came. So an artificial intelligence system to predict the optimal timing for mechanical ventilation, meaning for ICU patients, a two-stage prediction approach. This came from the Taiwan paper in 2022. where they have created a predictive model and they're categorized into two sort of a domains called Tri-Wean. In Tri-Wean, they used all these variables to determine the timing of weaning. So they put age, they fed all this data, age, Apache, TIS score, which is trauma injury severity score, FiO2, PEEP, and respiratory rate. And they found that the accuracy of the AI algorithms to predict the timing of weaning by putting these variables and analyzing these variables and guiding decision making was 68.6 to 77.4%. And then they had a second predictive model with algorithms where they fed 26 variables. So any AI algorithms, the more data points you have, better would be its ability to create a prediction model. That's what this particular study showed. And when they put a wean mechanical ventilation model, they took all these other variables, age, Apache, TIS, and they added on tidal volume to the pressure and SBT, and they even added Glasgow Coma score, and they put whether someone has had fever. So in addition to Tri-Wean variables, they put these additional variables, around 26 variables, 20 features, and they found that the accuracy tended to increase from 77.4 to 84.2%, which means to say this algorithm that they created as a predictive model to determine which patients can be weaned effectively had an accuracy of up to 84%. So, and if you saw the previous one based on the flow rate and resistance, so flow rate and you could determine the compliance and resistance is something with 99 accuracy. So these models seem to be getting better and better with its ability to determine the timing of weaning is what we could deduce. And what about AI in mechanical ventilation? So this has been shown to identify the dyssynchronies that prevail and assessing the response of the ventilator to the patient and patient's response to the ventilator. And this was a study they did, Chen et al., where they used AI algorithms to assess 5,899 breaths in a patient on ventilator, and they found 58% of the breaths were not as effective or were not optimal, and sensitivity and specificity was up to 98%. And this was another study, Blanche et al., where they used AI algorithms to compare the scalars and the pressure volume loops, and they found there was a discordance. There was a deviation of this pressure volume and the scalars by up to more than 42%. And they took 1,024 breaths in this particular Blanche et al. And the sensitivity, if you look at sensitivity and specificity, is very high. It means its ability to predict variable degrees of dyssynchrony in the patient. So what we believe is optimal ventilation we're doing, there is a lot of different spectrum or different extremes of dysynchrony. It may not be very gross dysynchrony that you are able to identify clinically, but from breath to breath, there were elements of dysynchrony up to 50% of the time in the ventilated patients. And Rem et al. And Adams et al., they tried to ascertain the dynamic hyperinflation by looking at the ratio of exhaled tidal volume and inhaled tidal volume. And even if you see the AI algorithm's ability to predict DHI by taking the ratio of exhaled and inhaled tidal volume, sensitivity and specificity was more than 90%. So, and all these algorithms have been incorporated into a software called Better Care, which is incorporated in certain new age ventilators. So, what this whole data sets have shown you, so if you look, how much ever you look into the literature, currently in intensive care, in respiratory, these are the studies that are available. So, if you have to sort of summarize as to what is happening, so resistance and compliance can be calculated breath to breath with more than 99.4% accuracy was shown in the study. The timing of weaning by inserting all these variables and looking into an algorithmic way is able to predict up to more than 80%. If you take 20 variables as to the wean MV sort of a model, its ability to predict the timing of weaning was more than 80%. And then what we realized is the phenotyping of ARDS is possible by feeding in the variables to delineate and see if it is P1 or P2. So this is the three advancements that have happened. The fourth advancement is to minimize the asynchrony or dyssynchrony. So there are algorithms which have been developed, and this has already been included in the new age ventilators as a software called Better Care. So this is all the advances that is happening in the respiratory. So it's all exciting. Maybe in the next snippet, I will talk about what are the AI advances that is happened in sepsis, so on, and I looked into AI advancements that has happened in the AKI, so on and so forth. So this is a snippet series, friends. So that's all we have at this point of time with regards to AI advancement in respiratory care. So request you all to submit your valuable work to Journal of Acute Care, and you can visit my website to refer to this lecture. So I think when you look into the AI literature, friends, there are journals dedicated to AI in healthcare, and these articles we may have to deliberate upon because they're coming more from the engineering standpoint or more from algorithmic standpoint. So it will be exciting. Maybe we should start discussing these journals also, and we may have to learn certain different ways of how they are looking at analyzing the data. So thank you, friends. Thank you, one and all.